Blood. Today we're going to be talking about blood. Blood is a fluid connective tissue. Who would have thought it was a connective tissue? But it is. It's made out of plasma and formed elements. Plasma is different from serum in that plasma still has the clotting factors. Serum, the clotting factors have been removed. So if you were going to give a patient they just needed antibodies, you could give them serum. If indeed they needed clotting factors as well as antibodies, then you would give them plasma. If they need cells as well, then you could give them whole blood. The formed elements are called formed elements because they're particles, but they're not necessarily whole cells. Now, the leukocytes are whole cells, white blood cells. Erythrocytes are your red blood cells, and platelets or thrombocytes are just little particles of cells. When pulling a blood sample, if you put an anticoagulant in it right here, you spin it down, you will have 3 layers. Your layers, the lower layer will be your erythrocytes. This middle layer, which is almost difficult to see, is your buffy coat. It consists of leukocytes and platelets. The plasma will be the top portion. Now, if you have entirely too many red blood cells in a sample, so you have a high percentage, maybe they come all the way up to here. I guess I should be on red. If they come all the way up to here, chances are your patient is dehydrated. If, on the other hand, the red blood cells ended, see if I can change back to a different color, right here, and the rest was all plasma, then you probably have an anemic patient. Well, you do have an anemic patient. So we call our hematocrit the percentage of blood volume that is red blood cells, and it's an indication of how the red blood cell count compares to other parts of blood. Males, 47 plus or minus 5%, females, 42 plus or minus 5%. Because of testosterone, males make more red cells. Premenopausal women also lose red cells because they cycle each month. Okay, it's sticky, opaque fluid, red to dark red. Arterial blood is bright red. Venous blood is bluish, dark red. The pH is 7.35 to 7.45. The temperature is 38 Celsius. Of course, this is core blood. It's a little warmer than the more surface body temperature, about 8% of all weight. Average volume, I would just say 5 liters. Now, that's almost silly. You think about a 100-pound person versus a 500-pound person, but that is an average. Distribution of functions, distribution of oxygen and nutrients, metabolic waste, hormones, regulation of body temperature. If you're too hot, you bring blood to the surface to cool you down. If you're too cold, you constrict vessels and holds heat in. The pH of the blood is normalized by buffers within the blood itself, and you have to have adequate volume of fluid in the circulatory system to be able to do the functions that blood needs to do. It has its own protection against blood loss. Plasma proteins and platelets cause clot formation. Infection, we have antibodies, complement proteins, white blood cells are all in the bloodstream to get rid of outside invaders. Plasma is 90% water. Proteins are made by the liver, 60% albumin, 36% globulins, fibrinogen, which is for clotting, 4%. Now, these plasma proteins made by the liver are essential for keeping water pulled osmotically into the bloodstream. You remember about our little imaginary cell we soaked in salt and the water got sucked out? Well, at the capillary level, water tends to leak out of vessels, and these plasma proteins osmotically pull it back in. So liver failure patients will have fluid in their extremities as well as their abdomen. Also, blood plasma carries a nitrogenous byproducts of metabolism. And when we say nitrogenous, we're generally thinking about protein metabolism. It also contains lactic acid, urea, creatinine, many waste products, uric acid, nutrients, glucose, carbs, amino acids, electrolytes, sodium, potassium, calcium, chloride, bicarb, all of which have to be at exactly correct levels. Respiratory gases are transported, hormones are transported. White blood cells are the only complete cells. Red blood cells have no nuclei and no organelles. Platelets are simply cell fragments. Most formed elements only live a few days. Most blood cells originate in the bone marrow and do not divide. Lymphocytes are our exception. They're all formed initially in the bone marrow, but then they can clone themselves later. So this is a rather pinkish picture, but you see your erythrocytes here, your monocyte, lymphocyte, neutrophil, platelets. Okay. Erythrocytes, or red blood cells, are anucleate. That means they have no nucleus, and basically no organelles. They're filled with hemoglobin for gas transport, and that's all they really do. They're flexible, and they change shape, and they can get in and out of little bitty places. And they are the main contributing factor to blood viscosity or thickness. This is our biconcave shape. Looks like a donut that somebody didn't quite get the hole punched out of. This gives you great surface area for each part of the internal volume. It makes the best possible shape for exchange of gases. So surface area is huge. It's mostly hemoglobin and water. No mitochondria. They can't burn their own oxygen to make ATP. If they make any ATP, it has to be anaerobic. Erythrocyte function is to transport respiratory gases. Hemoglobin binds reversibly with oxygen, and its structure, it's made up of a protein globin. Let's go to the next page. Here's the globin chains, and this is the heme groups here. And those heme can bind to, you have 4 heme groups, and each of those can bind to an oxygen. So you get 4 oxygens for each hemoglobin. And they're bound rather loosely. So oxygen is loaded in the lungs and it produces oxyhemoglobin. But when you get out to a low oxygen area, such as the tissues, let's say our big toe, the oxygen unloads and to feed the toe. And then as it's going back in the venous blood, it's a darker red or blue because now we have deoxyhemoglobin. It's been reduced instead of oxygenated. Okay, now carbon dioxide also lives in the tissues and is transported but it's not the same size oxygen does. About 20% of the CO2 is transported on the hemoglobin. Hematopoiesis means making red blood cells. Not just red blood cells, blood cells. Blood cell formation occurs in the red marrow. Now, in infants, small children, all of the long bones. But then we end up in the generally just the girdles and proximal epiphysis of the humerus and femur, the girdle being things such as the pelvis. Hematocytoblasts are your hematopoietic stem cells, and they give rise to all the formed elements. So hematocytoblast becomes a committed stem cell, and then it becomes eventually a normoblast, a reticulocyte, and then an erythrocyte. So if you're rapidly making red blood cells, you may actually see some reticulocytes released into circulation, or even possibly nucleated red blood cell. Now, blood cell production needs to be correct, because if you have too few, you have tissue hypoxia. Too many, you get sludge blood, increased blood viscosity, and it depends on hormonal controls, erythropoietin specifically, and adequate supplies to make the raw ingredients of making a red blood cell. Iron, amino acids, B vitamins. Now, erythropoietin is a direct stimulus for erythropoiesis. It's released oxygen levels, then erythropoietin will be released. So patients with kidney failure may become very anemic due to not having this erythropoietin released. Hypoxia can come from hemorrhage, increased red blood cell destruction, hemorrhage, of course, just bleeding, red blood cell destruction, sickle cell disease is one of the sickle cell crisis is one good reason why you would have red blood cell destruction. Insufficient hemoglobin, iron deficiency is a good example on this. Reduced availability at high altitudes. There's just not enough oxygen there to meet your needs. Erythropoietin causes rapid development of committed bone marrow cells. Reticulocyte count will increase in a day or two. Testosterone enhances erythropoietin production, and that is one reason why the red blood cell count is higher in males. You have to make red blood cells, you have to have amino acids, lipids, carbohydrates, iron. However, we recycle a lot of our iron. It's stored in hemoglobin, liver, spleen, bone marrow, in the cells as ferritin, hemosiderin. It's transported down to a plasma protein called transferrin. Okay, you have to have B12 to make red cells, and folic acid. These are necessary for synthesis and cell division of any cells. Okay, lifespan 100 to 120 days. Old, fragile red blood cells will start to degenerate, and then they'll be filtered out by the spleen, and macrophages in the red marrow in the spleen destroy those red cells. Okay, heme and globin are salvaged for reuse. Iron is recycled. Heme is degraded into a yellow pigment called bilirubin. Liver secretes the bilirubin in the bile. This gives you the idea right here. See the word yellow? Liver failure patients become yellow in color because of the buildup of bilirubin. They can't make bile, so they can't get rid of their old bilirubin. Any kind of hemolysis, like a sickle cell crisis patient, may have yellowish pigment that you see on light parts of their skin, hands, feet. Degraded pigment leaves the body in the feces, stercobilin, and then the globin is metabolized down into amino acids. Anemia is the blood having an abnormally low oxygen carrying capacity. It's not a disease, it's actually a sign of some other disease. And blood oxygen levels cannot support normal metabolism. Fatigue, paleness in color, shortness of breath, chills. They just feel plain terrible. Okay, causes: insufficient erythrocytes. The most obvious, hemorrhage. Now this could be acute, like you get an injury, or chronic, you get colon cancer. Hemolytic, the cells rupture. Sickle cell crisis is a perfect example. Aplastic anemia. You quit making new red cells. Chemotherapy, radiation therapy, and a particular antibiotic called chloramphenicol can cause aplastic anemia. It is still labeled for humans because it will kill most any germ out there, and if you're going to die anyway, most people don't get this reaction, so they'll try it on you. Okay, you can have anemia just because even though you have enough red cells, you don't have enough hemoglobin. This is generally from iron deficiency. You may have secondary iron deficiency as a result of hemorrhage, or you may not take in enough iron, or you may not absorb iron properly. And cooking in an iron skillet supposedly helps you have enough iron in your diet. Males and postmenopausal females may not even have much of a dietary requirement for iron because of recycling in the body. Pernicious anemia is a B12 deficiency, and it's caused by a lack of intrinsic factor in the stomach that you need for absorption of B12. And it either requires injections or a B12 that you put under your mouth and it bypasses the stomach. Sickle cell disease is a genetic disorder. Defective genes code for abnormal hemoglobin and any kind of stress. They become sickle-shaped. So this is a sickle cell, a stressed-out sickle cell. This is a normal cell. Now, it might make people wonder how that could still be possible in the human population. Why did natural selection not take care of it? Well, and this is on almost all standardized biology tests. So if you are a sickle cell carrier, if you're infected with malaria, each red cell that is infected with malaria will sickle up like this and be taken out of circulation by the spleen, and therefore protects you from malaria. Of course, if you have no medication and you have sickle cell disease, you're not likely to make it to reproductive age. But carriers have a great advantage in areas like Africa, which explain why we have sickle cell disease in our African American population, where it's not particularly common in our Caucasian people. Okay, and this is supposed to be from sickle cell blood. This blood cell is slightly abnormal. This one's slightly abnormal. They're not as extreme as one would hope. I just thought you would enjoy what frog blood looked like. This is normal frog blood, nucleated red blood cells. Polycythemia is an excess of red blood cells with increased viscosity. Now, polycythemia vera is, you can have a genetic polycythemia, you can have bone marrow cancer, you can have secondary polycythemia, such as you've been in high altitude for a long time, then you come back down to normal altitude, blood doping. Cheating athletes freeze their own blood, have it put in before the athletic event. Very dangerous, very dumb, and very illegal. Okay, leukocytes are your white blood cells, very small portion, less than 1% of the total blood volume. They leave capillaries by a process called diapedesis. That's where they just ooze between the capillary cells. They move much like an amoeba, amoeboid motion, and they go towards chemicals, and that's called positive chemotaxis. Leukocytosis is when your white blood cell count is too high, over 11,000, and it's generally caused by bacterial or possibly viral invasion. Leukopenia is when you have a low white blood cell count. Say if it's 4,000, you have not enough white blood cells. Now, bacterial infections could use up all your white blood cells, but generally, if you have an extremely high white blood cell count, one thinks of a bacteria. If you have an extremely low white blood cell count, one guesses at a virus. Now, there's no test out to prove that yet. This is showing the numbers, not the volumes, but platelets, there's a whole lot more platelets than anything else, leukocytes and erythrocytes. Yet, as volume, the white blood cell, the red blood cell count makes up tremendously more than these two combined. Now, a differential white blood cell count, the neutrophils make up 50 to 70%, eosinophils 2 to 4, basophils 0.5 to 1. These are your granulocytes. Agranulocytes, they have no granules, are your lymphocytes and your monocytes. Granulocytes are your neutrophils, eosinophils, and basophils, and they're called granulocytes because when stained with right stain, which is the proper stain to stain blood with, cytoplasmic granules can be seen. They're generally larger and shorter lived than red blood cells. They have lobed nuclei and they're phagocytic. They eat stuff that needs eating. This is a neutrophil right here. They're also called polymorphonuclear leukocytes and eat stuff, bacteria particularly. An immature white blood cell, neutrophil, has a banded nucleus. So if this is a white blood cell, it has a banded nucleus. And then as they become mature, they become segmented nucleus. So therefore, we call them polymorphonuclear leukocytes. So you can tell how severe or how acute a patient's infection is if they have a lot of immature red cells, white cells, neutrophils, then we know that they have an acute infection because they're having to make a lot of new ones. Okay. Eosinophils stain red because the eosin stain is red. These are increased in the case of allergy, parasitism, and also fungal infection. G-U-S, there we go. That is an eosinophil right there. Basophils, they're big, they're very rare, they're purplish, almost blackish looking granules. They release histamine. It's an inflammatory chemical that causes vasodilation and also draws other white blood cells into inflamed sites. You rarely see these when you do a blood smear. Now, never ever will you see a neutrophil that looks like that. Those granules are not there. You don't see them. They're more like the ones I showed you several slides back, which it doesn't seem to wish to go back quickly. Oh, well, there's one. That's much more realistic. This is a neutrophil. That's what they truly look like. But this is a nice fantasy world picture. Eosinophils have the red color, and then basophils have the black color. Agranulocytes are your lymphocytes and your monocytes. Lymphocytes have a circular nucleus, thin rim of cytoplasm, and these are huge in immunity. Most of them live in lymphatic tissue. They don't hang out in the bloodstream. They go to lymph nodes, spleen, and things like that and hang out. But there's one that managed to. See, almost no cytoplasm, mostly nucleus. And we have two types of lymphocytes, T cells and B cells. B cells mature in the bone marrow. T cells mature in the thymus. B cells are involved with the immune systems. They make antibodies. Actually, they clone themselves into plasma cells, which then produce the antibodies. T cells attack virus-infected cells, tumor cells. So we say T cells are for cell-mediated immunity. B cells are for humoral immunity or antibody-mediated immunity. Monocytes are the largest cells. They leave circulation and become macrophages. They're phagocytic. They're crucial against viruses because they eat the whole cell that contains the virus. cells that have internal parasites, they eat those, chronic infections. They also activate lymphocytes to mount an immune response. Okay, this is a lymphocyte. This is a monocyte. This is showing a little bit about the formed elements. See, the erythrocytes are red blood cells. Take 15 days to develop, live 100 to 120 days. They're for oxygen transport. Neutrophils, again, take 2 weeks to form, live anywhere from 6 hours to a few days, and they phagocytize bacteria. Eosinophils, 14 days to develop, live about 5 days. They kill parasites. They have a role in allergy, asthma, as well as fungal infections. Basophils take anywhere from a day to 7 days. They may live just a few hours. They release histamine. Your lymphocytes, days to weeks to develop. They may live hours. They may live your entire life, and they mount an immune response either directly, as in your T cells, or through antibodies, as in your B cells. Monocytes leave the circulation and become macrophages out in tissues. Platelets are just particles from a megakaryocyte, and they seal plugs that are bleeding, seal holes. Leukopoiesis means making white blood cells. So we go back to our old friend, the hemocytoblast, stem cell. And it divides into myeloid stem cells and lymphoid stem cells. Lymphoid stem cells of the white blood cell factory only go to lymphocytes. All the other white blood cells come from the myeloid strain here, the myeloid clone. So eosinophils, basophils, neutrophils, and monocytes all come from myeloid stem cells. Okay, leukocyte disorder. Leukopenia, as already mentioned, is an abnormally low white blood cell count. It's often used due to a viral infection. Leukemia are cancers involving the white blood cells, and they're named according to the abnormal white blood cell clone involved. Myelocytic leukemia involves myeloblasts. Lymphocytic leukemia involves lymphocytes. Acute leukemia is usually associated with children, whereas chronic leukemia is usually associated with older people. Leukemia is a treatable disease, though it could be a death sentence. It's not necessarily anymore. What happens with leukemia, the bone marrow becomes totally occupied with the cancerous cells. So you can't make your good white blood cells. You have non-functional white blood cells. You have hemorrhage. You have lack of good red blood cells, treatments, radiation, anti-leukemia drugs, and bone marrow transplants. Platelets are small fragments of megakaryocytes. They form a temporary plug, platelet plug, also that seals breaks in blood vessels. Platelets are also thrombocytes. So here's your hemocytoblast becomes a megakaryoblast, megakaryocyte, and then platelets are just little sections of it. Hemostasis means stopping blood, and it's 3 steps: vascular spasm, platelet plug formation, and coagulation. Step 1, the vascular spasm. Smooth muscle contracts. You get vasoconstriction. It stops a lot of the flow of blood. Then platelets are attracted to the damaged vessel, the lining wall here, and they start to fill up in this clog, in this hole, clogging it up. And they stick together because they release chemicals that make other platelets stick together. So you get a big clot formed. And then coagulation is the formation of a fibrin mesh. It has 3 phases. First is you have prothrombin activator being formed. It is converted, prothrombin activator converts prothrombin into thrombin. Thrombin catalyzes fibrinogen, which is in the liquid, is dissolved as a liquid into a fibrin mesh. So it pulls thrombin pulls fibrinogen out of solution, and you get this mesh, much like in this picture, to stop up the hole. Let's try that again. Now, they have actin and myosin in the platelets, and they contract, squeeze out some of the serum out of the clot. Then the clot starts to retract and repair itself. The platelets produce a chemical or growth factor that rebuilds the blood vessel wall. The endothelium of the vessel produces a growth factor that restores the endothelial lining. Within days, you really need to get rid of that clot. So fibrinolysis, lysis always means to break up. So in 2 days, the plasminogen in the clot is converted to plasmin by tissue plasminogen activator and factor 12 and thrombin. Plasmin here digests the fibrin. It's a fibrin digesting enzyme. A thrombus is a clot that develops and persists in an unbroken vessel. It can block circulation, cause tissue death in the individual. An embolus is a thrombus that broke loose and floated away. And they can be from the arterial side or they can be from the venous side. Pulmonary emboli generally come from the venous side. Well, they do come from the venous side, such as maybe your femoral vein has a clot, it breaks loose, goes up through the inferior femoral, up to the iliacs, up to the inferior vena cava, into the right atrium, right through the tricuspid valve, and then it goes right on into the to the ventricle, and then it goes out the pulmonary trunk, and the pulmonary trunk, like this, then forks and goes 2 directions to feed each lung. That pulmonary embolus is big enough to stop that section completely right there. Your patient is going to drop dead. So they're very dead, and that's a die now thing. Things that cause that are going to be a patient that won't get up, move around after surgery. They get a clot in those vessels. Other things may cause them, but that's one example. Cerebral emboli can cause strokes. Coronary emboli can cause heart attacks. So these are on the arterial side. Okay, thromboembolytic conditions. Aspirin is given 81 milligrams daily. Heparin is used around the time of surgery to prevent clotting. Warfarin or Coumadin is given to patients who are prone to get clots. People with atrial fibrillation have clots, or tend to get clots. Disseminated intravascular coagulation. I've only seen it in my patients in septicemia. It's also common in incompatible blood transfusions or a major complication of pregnancy. But what you have is widespread clotting inside the blood vessels, so little bitty clots. Now, because you used up all your clotting factors, you start to get bleeding, and the patient will end up dying. Basically, disseminated intravascular coagulation generally precedes death, so it's a very bad thing. Okay, bleeding disorders, thrombocytopenia. You don't have enough platelets. If you don't have enough, a severely low number, you may see petechial hemorrhages because you get little tiny hemorrhages all over. Now, this looks like a rash. Now, when a patient has disseminated intravascular coagulation, as on this last page, you may see petechiations, which looks like a little rash, bleeding, because they ran. Cause of thrombocytopenia, destruction of bone marrow, malignancy, or radiation. If the platelet count is below 50,000, that's diagnostic. You can give transfusion of concentrated platelets. And this is why, one of the reasons they always do blood work before surgery, because if the platelet count is low or thrombocyte count is low, and you do surgery, your patient may bleed out, and that's never a good day. Okay, another bleeding disorder, impaired liver function. The liver produces procoagulants, so you can't clot if you don't have a liver. Also prevents the liver from producing bile. If you don't have bile, you can't absorb fat, and also vitamin K, which is fat soluble. So if you have vitamin K deficiency, you're going to bleed. And let's see, hepatitis and cirrhosis. And the latest cause of liver failure, besides alcohol-induced liver failure, is fatty liver syndrome. And that just goes along with bad diets and our overweight people, and same ones that have type 2 diabetes. Okay, another bleeding disorder, hemophilia. We have different types. A is the most common due to lack of factor 8, and these you have to test, you can't just know. Hemophilia B, factor 9, these are clotting factors. Hemophilia C, factor 11 is missing. And in hemophilia, you're going to get prolonged bleeding in surgery. You get random bleeding into clots. You can treat these with plasma transfusions, injections of the missing factors. Before anyone knew anything about AIDS or they knew to screen for AIDS, a lot of children became infected with AIDS because they were being treated for hemophilia and they got contaminated blood. Okay, transfusions. Blood transfusions are used when you have substantial blood loss. You can give packed red cells, not the plasma, if you just need red cells for oxygen carrying capacity. Now, transfusion with incompatible blood can be fatal. We'll look at a little bit, we're not talking about Rh factors yet, we're just looking at the antigens. And if you notice, type AB blood is very rare, and there's a racial difference. Like type O blood, 79% of Native Americans have type O blood. Now the antigens are these little things pictured on the red cells. That's an antigen. And what the antigens are, they're kill me flags. It says, please, antibody, come attach to me, make me clump to my teammate, and I'll die. So type AB blood has antigens A and B, both on the red cell. It makes no antibodies. Now, the name of the game in blood transfusion, you worry about the donor blood being destroyed. You don't want to destroy the donor cells. Now, your own cells are not going to be destroyed because you have enough plasma to kind of water out their antibodies. So, type AB blood is considered the universal recipient. They're not going to die no matter what kind of blood you give them. Type B blood has B antigens on it, B kill me flags. So if you have type B antibody, it's going to destroy those recipient cells. So you can give anti-A antibodies. So you can give a person type B blood or type O blood. Type A has A kill me flags. So if they get anti-A antibodies, they're going to be destroyed. So they can get A or O blood. Type O have no antigens on the red cells. So they have antibodies. But they're universal donor because you're not going to destroy these cells. When you give these cells, they're not going to be destroyed because they just are used to the antibodies that your recipient puts out. Okay, Rh factor, it can affect with transfusion. You do have to check if you're Rh positive or negative. If you're negative, you will react to Rh positive blood, not the first time, but on the second time. First time you get it, you're sensitized to that blood. Second time you get it, you'll have a massive reaction. Now, one of the biggest places this happens, or it's a concern, since all blood is tested before it's given to people, erythroblastosis fetalis. An Rh negative mother has a baby with an Rh positive dad, and the baby is Rh positive. So it has Rh positive blood. So the Rh positive blood escapes into the bloodstream, it crosses the placenta, and the blood produces antibodies that destroy the baby's blood cells. This can be lethal to the children if it's not treated. What you do if RhoGAM, it's a serum, it has anti-Rh antibodies in it, give it to the mother, and several times, I don't remember the protocol, but it will prevent the mother from being sensitized. Now, if you're Rh negative and your husband's Rh negative and you have an Rh positive baby, your husband's going to be extremely mad because you have to have an Rh positive, one Rh positive parent to have an Rh positive baby. Okay, so the transfusion reactions, it's the donor cells you're worried about. You don't want the donor cells attacked by the recipient's antibodies or agglutinins. If you do, you're going to get, they're going to agglutinate or stick together. They're going to clog small vascular carrying capacity being reduced, and they're going to destroy kidney tubules and therefore the kidneys. Now this is showing some blood being tested. I won't go through all of them, but this is type A blood. When it's mixed with anti-A serum, it agglutinates, clots up. When it's mixed with anti-B, nothing happens. Type B blood mixed with anti-B, clots up. Type O blood is not going to agglutinate no matter what you mix it with because it just doesn't react to them. Okay, that's all for blood, and don't worry, we've got plenty more to talk about later. Thank you.